fever. So let's go through what is the normal value of hemoglobin, total white platelet, and ANC.
For hemoglobin, for male is 13.5 until 18 gram per deciliter. For female, 11.5 until 16. And for total white cell, it is 4 until 11 times 10 power of 4 liter.
And
For
get to the power of
4
per
per liter.
no,
And
times 10 to the power of 9.
okay.
Okay, platelet.
Okay. And for platelet is 150 to 400 times 10 power of 9 per liter.
Yes, correct. Okay,
Okay. And
ANC.
ANC is 1.528.
1.5 to 8. Yeah. So that means
Yeah.
instead of remembering the ANC, so you remember at least the neutrophil will be 50%, 50% of the total white normal value. Okay, so easier in that way. Okay, so 50% of the total white cell. Okay, good. Let's go through. So pre-phase chemo is the chemo that something like warming up. So it's a very mild dose before they go into the proper chemo, because we do this kind of pre-phase chemo in certain cancer, in certain hematological cancer, in order to prepare the patient into the proper chemo. The proper chemo will be very intensive, and sometimes when the count is very high, we want to reduce the chance of tumor lysis. We start with a small dose first instead of a big dose. Otherwise, the tumor will lyse at the same time and increase the risk of the tumor lysis syndrome. Okay. So what are the ECG changes of hyperkalemia? What are the ECG changes of hyperkalemia? Anyone?
Tall T, widened QRS, then absence of P wave.
The first changes will be
Tall T.
tau tended T, okay, followed by the changes that you mentioned, and a specific name for the ECG changes before the patient go into acid-solid. I'm sure you have learned the name. Do you remember? Sine wave, huh? Okay, try to look it up. It becomes something like a wave, sine wave, like that. Okay, so what to do if there is a spelling mistake, hyperkalemia? If there is a hyperkalemia, from the ECG changes.
We give IV calcium gluconate.
Okay.
Then we give salbutamol and insulin with glucose.
Okay, we usually do not give salbutamol. We should usually so we give the calcium gluconate. So what is the function of calcium gluconate? Is to
Cardioprotective.
So it has nothing to do to reduce the hyperkalemia. So the treatment that reduce the hyperkalemia is the insulin. It's the insulin itself. It's not the insulin plus the glucose. Glucose is given to counteract the side effect of the insulin. Okay. So list the condition that you learned so far that have both thrombosis and bleeding problem at the same time. So you have learned hyperviscosity syndrome can have bleeding and thrombosis. So what other conditions that you have learned?
Thrombotic thrombocytopenic purpura.
Very good.
disseminated intravascular coagulation,
Yes.
hemolytic uremic syndrome.
Okay, good. Okay, so these are the conditions that you learned so far. Let's go to the next slide. Okay, so I hope you all have go and read it. Okay, but I would like to excuse me. So hold on. Two. Okay, I would like you all to I'm sharing something else. Oh no, I shouldn't let you all see this. Oh, okay. Can you all do this? Can you all see my screen? Okay, can you all try to calculate? Oh, because the time is running out, now is 10 o'clock. Can you all take a picture of this? Take a picture of this. You all calculate. Later I'll give the group leader the answer. So you all counter check the answer of the corrected calcium. Okay. Maybe you all just take a picture. Then later you all calculate just to practice. Then later I give the answer to you all. Maybe I give the answer now lah. Actually, it doesn't matter. You all are big boy and big girl already. You all won't really cheat. Okay, so just okay. So this will be the answer. Okay. So you all copy down that. Later you all just try it out. Okay. Okay. Let's go to the other slide. Okay. So how does hematological tumor cause the superior vena cava obstruction? So just imagine a lymphoma. Usually it's a lymphoma. So the lymphoma can, the lymph node is outside the blood vessel. So it will cause extramural, when the lymph node is enlarged, it will cause extramural compression. But if the tumor is growing and growing, then later it penetrates the blood vessels wall, then it can be intramural and even intraluminal. But in the hematological setting, usually it is extramural. The intraluminal can be caused by the blood clot because when the blood vessels is compressed, the blood flow is not good, then the blood clot can form. Okay, so then you can have extraluminal and extramural plus intraluminal blood clot. Okay, so that's what I try to ask you all to think how it causes the SBCO. Okay, okay. So far, any question? Are you all okay? Oh, my goodness, okay, I shared the wrong thing just now. Okay, yeah, I'm talking about this. Sorry, I am talking about this. The SVCO. So the SVCO, the lymphoma can cause SVCO from the extraluminal and large lymph node. Then it can also include because of the compression, you can have intraluminal blood clot, intraluminal thrombosis. So this is how the lymphoma can cause the SVCO. So it might be different from the other tumor like CA lung, okay? It also can cause the SVCO, okay? So any question? So if No, we will take 5 lah, huh? We will just break for 5 minutes. And you all check out for the you all check out for this hematological hematologist hold on, sorry. Hematology discussion, lecture discussion. Okay. Can you all hear me?
Yes, doctor.
Okay.
Okay,
Yeah.
doctor.
So you all check out for the lecture. In 5 minutes time, we will continue with the seminar.
Kita tak check in
And,
tadi.
so the presenter for the hematology seminar, please get ready. Later you all will need to share your screen. So get ready. I want to see your face. I don't want to hear your voice only for the presenter. So can you all get ready your slides? Okay. So this one is for the checkout for the hematology lecture. Later, before the seminar begins, I will put up the check-in for the seminar. Okay, so we take 5.
Hey, doctor. Just now we checked in for the seminar, not for the lecture one.
Ready? Oh my goodness. Okay.
Yes, doctor.
Hold on. Okay, later, never mind, later I change. So I put the seminar one first. Okay, later I will interchange. Okay.
Doctor.
Hold on. I'm so sorry. Okay. So, okay, I'm sharing the seminar one. Okay, never mind. You all check out. Later, I will change the title. Okay.
Hi, excuse me, Prof.
Yes.
Some of us actually in early in the class, they didn't finish to check in for the like
Uh, so how, I think just now there are only 40 students checked in. So there will be three students, right? Three students did not check in for the previous session. Correct or not?
Yes, doctor.
Yes, doctor.
So, uh, so, so they can only check out lah.
But if you don't check in, you cannot check out, doctor.
Oh, okay. So I will manually check out for you. Okay. For all night. Can you? So you hold on. I get some pen. So the three students what is the staff number? What is the student number?
58866.
58866. Okay. Number two.
50842.
50842. Okay. Number three. There are three students. Altogether, you all got 43, right?
Yeah, yes, bro.
Yeah.
The other one,
Mm-hmm.
not sure who's there. Only two people contacted me. They cannot. So
Okay.
only two people contacted me. Not sure the
Oh,
other one. Sorry, bro.
Okay. Never mind. So, so it's okay. Never mind. So for the two students who did not check in for the lecture discussion just now, I will manually check out for you all. Don't worry. Okay. So I suppose. So all of you in already, huh? Okay. So if you're all in already, I've stopped sharing. So the presenter, please get ready to present. Okay. Cannot hear.
Hello.
You have to talk louder.
Now can hear it.
Very soft. Okay. I put my mic in 100%. Okay. Okay, you try again. Can you try to talk again?
Hello. Can you hear me? Hello.
Okay lah. I put 100% already. And it's still a bit soft. Okay. So you try to talk louder, please. Okay.
Alright.
So,
Good morning to Prof. 1 and my classmates. So today we are from Group C1. We'll be presenting on hematology seminar. So these are our outline for today's discussion. So first we will go to approach to the pancytopenia. Pancytopenia is defined as reduction in all major cell lines, which include hemoglobin in male less than 13 gram per deciliter, in female less than 12 gram per deciliter, white blood cell count less than 4 times 10 power of 9 per liter, and platelet which less than 150 times 10 power of 9 per liter. Basically, it is a combination of anemia, leukopenia, and thrombocytopenia. So to define the severity of pancytopenia, severe pancytopenia is defined as hemoglobin less than 6 gram per deciliter, absolute neutrophil count less than 0.5 times 10 power of 9 per liter, platelet count less than 20 times 10 power of 9 per liter, and corrected reticulocyte count less than 1%. So the presenting symptom of pancytopenia may be attributable to the anemia, leukopenia, and/or thrombocytopenia. Which anemia they can presented with fatigue, breathlessness, and cardiac symptoms such as chest pain and palpitation. Well, in neutropenia, they can be presented with febrile illness due to increased susceptibility to infection, and patients with thrombocytopenia may be presented with mucocutaneous bleeding or bruising. Thus, cytopenia should be suspected on any patient with unexpected anemia, prolonged fever, and bleeding tendency. So pancytopenia is not a disease by itself, but it is type of hematological finding that can result from a lot of causes. So some of the causes of pancytopenia include bone marrow infiltration, bone marrow failure, infection, peripheral pooling and destruction, and effective hematopoiesis. So we will go each causes one by one. So first is bone marrow infiltration. The bone marrow infiltration it occurs when there is an activity that occupies marrow space, which can lead to pancytopenia to direct effacement, interference with hematopoiesis, or concomitant fibrosis. Some of the causes are acute leukemia, myeloma, lymphoma, carcinoma, like in breast carcinoma and prostate carcinoma, hemophagocytic syndrome, and myelodysplastic syndrome. For bone marrow failure, failure here means it failed to produce adequate and functioning cellular component. So it will result in ineffective hematopoiesis, but there is no infiltration to the marrow. So most common cause is aplastic anemia, which defined as pancytopenia with hypocellular marrow in absence of abnormal infiltrate or increased fibrosis. For aplastic anemia, the causes can be divided into inherited and acquired cause. Acquired cause is the most common causes of aplastic anemia. For inherited cause, some of the causes include Fanconi anemia, dyskeratosis congenita, congenital amegakaryocyte thrombocytopenia, and Schwarzenberg syndrome. For acquired aplastic anemia can be caused by ionizing radiation, chemicals such as benzene, iodine, drugs such as chemotherapy drug, antibiotic, anti-rheumatic drug, and anti-thyroid drug. And it also can caused by
Suhaimi, your voice is getting softer.
I I think my mic problem, doctor.
Uh,
Try again lah. So for acquired bone marrow, for acquired aplastic anemia, known cause include ionizing radiation, chemicals such as benzene, organophosphate, drug including chemotherapeutic drug, antibiotics such as chloramphenicol, sulfonamide, anti-rheumatic drugs such as penicillamine, gold, anti-thyroid drugs such as carbimazole, propylthiouracil, anticonvulsant, and include immunosuppressant drugs. Other cause acquired aplastic anemia include infection, which caused by viral infection, such as hepatitis, Epstein-Barr virus, HIV virus. So next cause of pancytopenia is infection, which can be caused by advanced human immunodeficiency virus infection, which will then cause bone marrow failure, chronic hepatitis virus infection.
Suhaimi, can you go back to the previous slide?
Yes.
Previous slide?
Yeah.
One more? Another? Okay, number one. Okay, causes of, okay, so, next, sorry, next. Okay, yes, this slide. So you all have learned aplastic anemia in your year 3.
Yes.
So whenever, whenever we talk about aplastic anemia, usually we are talking about acquired idiopathic aplastic anemia. Okay, idiopathic aplastic anemia. So so please remember when we talk among doctors, right? When we say aplastic anemia, usually we are talking about the acquired idiopathic aplastic anemia, whereby no causes can be found. Okay, understand? Okay. Okay, continue.
So other cause of pancytopenia is infection, can be caused by advanced HIV infection, chronic hepatitis virus infection, which lead to tension pancytopenia also associated with aplastic anemia, Epstein-Barr virus, cytomegalovirus, herpes simplex virus, adenovirus and leishmania, which will usually cause pancytopenia via acquired hemophagocytic lymphohistiocytosis syndrome and disseminated miliary tuberculosis. What causes peripheral pooling and dissection mainly caused due to hypersplenism and SLE. In hypersplenism, there is peripheral pooling and dissection of cells in the intestine, which non-cause include congestive splenomegaly in cirrhosis and congestive heart failure, malaria, thalassemia, and Hodgkin disease. In systemic lupus erythematosus, it is as a result of autoimmune dissection and other mechanisms such as hypersplenism. So the last cause of pancytopenia is ineffective hematopoiesis. In one of cause is megaloblastic anemia, which result of folate and vitamin B12 deficiency, and it is usually characterized by presence of different morphological aspects of the maturing cell in the bone, causing ineffective hematopoiesis. And also acquired immunodeficiency syndrome (AIDS) also will lead to pancytopenia in the late stage. So based on the disease severity in the descending order, the most severe cause of pancytopenia is acute pulmonary leukemia followed by hemophagocytic lymphohistiocytosis syndrome, aplastic anemia, and the list continue.
Okay.
So approach to pancytopenia. So in pancytopenia, evaluation of pancytopenia require a careful history and physical examination. Because the cause of pancytopenia is wide, so we need to take a proper careful history and physical examination. So in history, we can get symptom of cytopenia, which like I mentioned just now, is there any dark urine or jaundice which might indicate hemolysis, fever, lymph adenopathy, and pain, which may indicate bone marrow mass, skin lesion, cough, hemoptysis, which can be due to disseminated fungal or microbacterial infection, weight loss, fever, and night sweat to rule out TB and lymphoma, and is there has any condition that predispose to leukemia like myelodysplastic syndrome or previous chemotherapy. So in physical examination, we can look for ATK, gum hypertrophy, look for any lymphadenopathy, hepatosplenomegaly, and skin which may indicate minor infiltration, fungal infection, or thrombocytopenia, and through neurological examination and mass at the plain site. So initial approach management of pancytopenia, first we need to secure the airway burden and circulation, establish the IV assays, give oxygen supplementation and maintain SpO2 more than 94%, regular monitoring of vital signs and ECG changes, discontinue the potential offending drugs if they have, and take blood for investigation such as full blood count with differential count, linear profile, coagulation profile, vitamin B2 and folate liver function test, viral studies, peripheral blood film, group cross-match in preparation for transfusion if indicated.
So Jaime,
Yeah.
so Jaime, you left one important investigation that you're supposed to take.
One important investigation. Blood culture sensitivity.
I cannot hear you.
Blood culture and sensitivity.
Yeah, you have to take blood culture and sensitivity. Okay.
Also blood culture and sensitivity. So next, we can do imaging investigation such as ultrasound, echocardiogram, and chest X-ray, and to alert hematologists, clinical lab, and blood bank. So initial management, we need to give a supportive care for any patient if they to replace the low in blood cell. In can give blood transfusion is platelet concentrate. However, platelet concentrate is contraindicated in TTP and HIT, and treatment and prevention of infection. Also, we can give antifibrinolytic agent which may be used to reduce hemorrhage in patients with severe prolonged thrombocytopenia, oral antibacterial and antifungal drugs for reduce the infection. And last, after we get the diagnosis, we will manage the disease according to the specific diagnosis.
So Jaime, let's go back. Yeah. So you only want to give oral antibacterial and antifungal. How about IV?
Maybe initial if they suspect in septic shock infection.
Usually, if you suspect the initial infection and you going to admit the patient, usually you will not start the oral, you will start the IV. So better don't specify as a oral because if the patient is in septic shock, are you going to give oral? So Jaime?
IV, doctor, no.
Yeah, so under your supportive care, instead of oral, I think you better you better delete the word oral, okay? Okay, continue.
So this is further investigation which why we do it, like blood count, like I mentioned just now. And last is the simplified version and how we approach to pancytopenia. So first, we need to do a clinical assessment, which followed by blood investigation, complete blood count, purple smear, corrected reticulocyte sign, which and diagnosis of pancytopenia is made when the hemoglobin, leukocyte, and platelet count is low than visual range. And usually, we need to do bone marrow aspirate and troponin required usually to establish the diagnosis of pancytopenia. So what we can see is there any hypocellular bone marrow or cellular bone marrow. So some of causes of hypocellular bone marrow include acquired aplastic anemia, constitutional aplastic anemia, bone marrow lymphoma, and others. So then we need access for drug exposure to look over the cause, viral serology, and for the cellular bone marrow, it usually can be divided into primary bone marrow disease and secondary bone marrow disease. So primary bone marrow disease usually caused by myelodysplastic syndrome, leukemia, lymphoma, whereas the secondary systemic disease can be caused by megaloblastic anemia, hypersplenism, and infection. So after we get the definite diagnosis, we need to treat according to the specific disease.
Good morning, Prof. and all my fellow friends. Next, I will be continue with the management of complication of blood transfusion.
Okay.
Next. So for the introduction, the most frequent adverse event that associated with the administration of the blood product is the transfusion reaction. It can happen up to 1% of the transfusion, with the severity ranging from the mild event even to the life-threatening events. It can be divided into acute, which happen up to 24 hours after the transfusion. And then for the delayed transfusion reaction, it happened after 24 hours up to 30 days post-transfusion. And it can be further divided into the immunological and also the non-immunological cause. Here are some of the example of the transfusion component. For the first one, which is the PET red cell, it is indicated when there is the need to improve the oxygen transport and also the delivery to the peripheral tissue or organ. For example, in the symptomatic anemia patient. There are no absolute control indication for the PET red cells. However, it is ineffective if we transfuse in the condition of like chronic iron deficiency anemia, in which we can use the iron supplement to improve the hemoglobin in the safer way. And also for the megaloblastic anemia, we can also using the hematinics. And then next for the flash frozen plasma,
Okay, megaloblastic anemia is caused by what?
cobalamin and also the folate deficiency.
Okay.
So for the fresh frozen plasma, it is obtained from the whole blood through the process of centrifugation and also the plasma apheresis. So for the contraindication, is contraindicated in the patient who is having the IgA deficiency and also having the anti-IgA in their body. So when they receive the blood product with the IgA, they will experience the anaphylactic reaction from the transfusion itself. So they only can obtain the blood product from the IgA deficient donor. And then another contraindication is the heart failure and also the pulmonary edema patient, in which they will have the higher risk of getting the volume overload after the transfusion of fresh frozen plasma. And it is effective over the condition in the coagulopathy, which can be corrected using the vitamin K or any correction of the immune deficiency or any congenital or acquired clotting factor deficiency without the hemorrhage happening, or hyperproteinemia in the condition of chronic liver disease, protein losing enteropathy or nephrotic syndrome, or only for the nutritional purposes or expansion of the circulatory volume. And for the next is the platelet. It is indicated only to prevent the hemorrhage in the patient with the thrombocytopenia or also the platelet function defect. However, it is contraindicated in the thrombotic thrombocytopenia purpura and also the heparin-induced thrombocytopenia because they may have the higher risk of getting the arterial thrombosis. And it is also ineffective in the autoimmune thrombocytopenia because in this patient, they already have the preformed antibody. So whenever you infuse the new platelet into the body, they will get attacked by the antibody itself and lead to the rapid destruction of the platelet. Thanks. Yeah, here is the classification showing the acute and delayed and further divided into immunological and also non-immunological causes, which I will further explain later. Okay, next. So here is the general management of the transfusion reaction. First, we have to recognize the patient is having the transfusion reaction right now, and we must stop the transfusion immediately. And then we have to inform the doctor in charge to assess the patient right away.
Liu, you are the doctor.
Oh, so I come to assess the patient right away. And then
Yeah, the nurse will
management,
inform you. The nurse will call you out, and then what do you say over the phone? The nurse will call you out.
I will come now right away.
You should
Assess the
say,
patient.
have you stopped the transfusion? The nurse will ask you.
Okay.
Okay, you will say, have you stopped the transfusion? If not, straight away ask the nurse to go and run at the patient and stop the transfusion. And you say you will come immediately and see the patient. Okay, you are the doctor. Okay.
Oh, okay. So
thank
I
you.
will ask the nurse whether they have already stopped the transfusion or not. If not, I ask the nurse to run straight away to stop the transfusion. And then I go and assess the patient. And then depending on the type of the reaction and also the severity of the reaction, I will start my management. And I will
Yes.
first administer the antihistamine. For example, the coferamin, 0.1 milligram per kg.
So the flow chart here, you put administer antihistamine. Then the next one is administer antipyretic. That one you better don't put it down, or you put as a footnote or the sub point, because this will be only this can be given according to after your assessment. It is not a must.
Okay.
It is not a must. You understand?
Yes.
Okay. But
So if the
yes.
if the patient is having a febrile non-hemolytic transfusion reaction, then I will administer the antipyretic for the patient. And then after all kind of management, I will monitor the patient whether see whether there is any improvement of the sign and symptom. And then if there is worsening of the symptoms, then I will proceed to the further management.
Yeah. Okay.
Okay, next. So here are the steps to be taken to allow for the investigation. First, I will collect 8 to 10 ml of the venous blood in the plain tube and send for the antibody identification. And then I will collect another 2 to 5 ml of the venous blood and send for the full blood count. And then I will collect the urine sample of the patient. Before I send to the lab, I will do the inspection of the urine first, whether it's brown in color, because it may indicate the hemoglobin urea. And then after that, I will send to the lab straight away to check for any presence of hemoglobin, albumin, and also the presence of the red cells. And then the remaining blood bag, which containing the partially transfused blood, and all the blood bag that have a cross match for the same patient at the same time of request should be examined for any presence of the free hemoglobin or any discoloration. And then after 24 hours, I will collect the blood sample again for further testing, send for the full blood count and also the urine specimen to check for any presence of hemoglobin urea. And then after that, I will complete.
Okay, very good. So the flow chart like that, okay, which is correct. But will you do this for a patient who develop febrile transfusion reaction?
No.
No, right? So this is not for all the patient. Or some patient develop allergic reaction, not anaphylaxis, allergic reaction or some urticaria. Okay, will you do that also?
No.
No, right? So this is only for certain type of reaction because the febrile transfusion reaction and also the allergic reaction, the mild allergic reaction is pretty common. So if you do all this for all the patient, then I think it is unnecessary lah, unnecessary. Okay. So please, all of you, please remember it is not for every reaction. Okay. Got it?
So
Yeah.
after that,
Continue.
okay, so we will complete the report of reaction to the blood and plasma transfusion form. And after all the investigation result come back, then we fill out another form and send to the blood bank and also the National Blood Center. Yeah, next. So here is the form showing the report of reaction to the blood or plasma transfusion. Okay, next. This is the second page of the form. Next. Here is the form of the adverse transfusion event which we have to send to the blood bank and also the National Blood Center. So for every case of the adverse reaction, we must report it. And then if there is a case we found out to involve a seropositive donor, we should do a look back and also the recall procedure. And then the IC number and also the donation date of the particular donors must be submitted to the surveillance unit of the National Blood Center. Okay. So here are the life-threatening blood transfusion reaction. Okay, next.
Hey, go back. Go back. I disagree with some of the things that you put it in.
Yeah.
You.
Yeah.
So which one will you want to remove?
The febrile non-hemolytic transfusion reaction and also the allergic transfusion reaction.
Yeah, you better remove that because it is not life-threatening. Okay. But they are the most common transfusion reaction. Okay.
Okay. Okay, next. So for the first one, for the acute hemolytic transfusion reaction, it happened when we transfuse the ABO incompatible blood to the patient. So in the patient already having the antibody, and then when you transfuse the ABO incompatible blood, so the antibody will go and attack the red blood cell antigen, and it will further causes the intravascular hemolysis of the transfused blood. And even 50 to 100 ml of the transfused blood will cause the patient to become symptomatic. Sometimes
Not
it even
50 to 100. Not that is quite a lot already. It is smaller amount than that. The patient is already symptomatic. Oh yeah, put it there. 5 to 10. Sometimes the small volume like this, the patient is already symptomatic because it is very, how to say, it is very, very allergenic, very, very allergenic. The patient will be symptomatic very fast. Okay.
Okay. So the patient will be first presented with the triads such as fever, flamping, and also the hemoglobin urea. And then there are also associated symptoms like nausea, vomiting, headache, restlessness, agitation, and then flushing, urticaria, and chills. They may experience other side of the pain like lumbar pain, chest pain, and also the abdominal pain, even at the venipuncture site. They may also experience the shortness of breath, hypertension, and also presence of the hemoglobin urea and jaundice, which indicating of the hemolysis and also the bleeding. They may also experience the acute oligouric renal failure secondary to the renal tubular necrosis. So for the investigation, we must first check for the clerical error, means while in the handling of the donors and also the recipients group cross-match blood specimen. So the blood unit and also the post-transfusion sample must be sent back to the blood bank. First, we must repeat the group and cross-match again. And then-
This is all the one that you had mentioned just now, the blood test that you have to send. Okay, so we will not repeat that. So I just add a point about the point about acute hemolytic transfusion reaction. This is rarely occur, but once it occur, it is a catastrophe. It is a disaster, and you must be able to you must remember this can happen. Hopefully, you never happen in the whole life as a doctor. Hopefully, but once it happened, you have to act very quickly, and there is extra point that you have to manage. Liu, you go back to the flow chart that you put before, the one that if you there is a reaction,
okay.
go back. The one, yeah. Go back. The one that with the flow chart one. Okay. Bukan. No, not this one.
Previous one.
Yeah. So the nurses inform you, make sure the nurse already stopped the transfusion. You go and see the patient and decide what kind of reaction is that. So if you think that it is a acute hemolytic transfusion reaction, as I said, hopefully it never happened to you as in your life as a doctor. But if it does happen, you think that the patient is ill. It is not. There is something wrong. It is too ill for a common reaction. Okay, and you suspect it is an acute transfusion, acute hemolytic transfusion reaction. One extra thing that you must put it in will be not only stop the transfusion, so you have to detach the connection to the granula, and you need to try to use an empty syringe to suck up whatever remaining inside the granula, the dead space or whatever blood that is surrounding there, trying to remove as many incompatible blood as possible, roughly. If you can take out roughly about like 5 cc or even 10 cc, and then you have to set another, you can keep that line. If the line is very difficult to set, you can keep that line, or or if you think that it's easy to get another line because the vein very big, then you can remove that granula, remove the granula. Okay, but usually we will have a secure granula before you remove that the granula that used for the transfusion. Okay, so you try to suck up the blood if you are using an empty syringe. So just one extra point for the acute hemolytic transfusion reaction. Okay, Liu, okay, you can continue.
Okay. Yeah, this one already just now explained by doctor.
Okay.
Okay, next. So for the next one is the transfusion-associated acute lung injury. So it happens when the leukoagglutinin in the donor plasma react with the patient leukocyte. So it will lead to the formation of the immune complex and it become trapped inside the pulmonary microcirculation, further causing the vascular obstruction and also the leakage and pulmonary edema happen. So the reactive lipid product is from the donor blood cell membrane. They are capable of neutrophil priming and it will further causes the damage to the pulmonary capillary endothelium. So these symptoms can happen during the blood transfusion or within 1 to 8 hours after the transfusion. Usually the treatment is needed and if not, the patient will be rapidly fatal and more than 90% of the patient will recover. So for the clinical features, the patient will present with a fever, chills, dyspnea, and also the non-productive cough, cyanosis, and also the hypotension. So for the treatment, it is usually supportive treatment until the patient start to recover in 48 hours. First, we will give the diuretic to relieve the pulmonary edema, and also the oxygen supplementation as the patient presented with the symptoms of acute respiratory distress, and also the intravenous steroid and adrenaline, and the patient may require the ventilatory support. And then we must report this transfusion reaction to the blood bank, so no further usage of this donor blood for the future transfusion. Next. So for the next one is the transfusion-associated circulatory overload, which this pulmonary edema is cardiogenic origin. So it encountered in the patient in the cardiac failure and also the premature neonate. So the patient will present with the restlessness and also cough with or without pin sputum, chest tightness, dyspnea, tachycardia, cyanosis, and also elevated jugular venous pressure, and there may some cracker over the lung. Yeah. So for the treatment, because of the patient is experiencing the circulatory overload, we must stop all the intravenous fluid, and then we must place the patient in the upright position as the patient may have the optonia in the lying position. And then we start administer the patient with the diuretic and also the oxygen. Minimize the risk in the by giving the red cell concentrate or slow down the rate of infusion and also limit the transfusion to the minimum requirement. Next. So for the febrile non-hemolytic transfusion reaction, it is defined as the rise in the body temperature more than 1 degrees Celsius associated with the chills, cold, rigors, rushing, tachycardia, and also the discomfort. So it's more common in the patient who have been transfused before or the pregnant woman. So for the pathogenesis, is actually the reaction in between the recipient's anti-leukocyte or the HLA alloantibodies and together with the transfused white blood cell, and they react and they release the pyrogens. They also release other kind of bioreactive substances like interleukin-1 and also the interleukin-6, which lead to the febrile reaction. Yeah, so for the treatment, we can give the antipyretic such as oral paracetamol and also the antihistamine such as the intravenous diphenhydramine and also the steroid for the intravenous hydrocortisone and slow down the infusion rate. But before that, we have to exclude the more harmful reactions such as the hemolysis reaction or the bacterial contamination. After we exclude all these causes, then we can continue the blood transfusion. And this febrile non-hemolytic transfusion reaction can be prevented by leukodepletion. Okay, next. So for
Can
the
be
next one,
reduced, but it cannot be totally prevented
can be reduced.
because it can be reduced but cannot be totally prevented because sometimes it is the other substances in the blood, not only the leukocyte. Okay. Continue.
So for the allergic transfusion reaction, it is the IgE antibody react with the soluble antigen in the infused plasma, lead to the mast cell degranulation, and they will further cause the histamine to be released. So when this histamine release, it will produce the allergic reaction like rash, hive urticaria, or itching and erythema. So for the treatment, we can slow down the transfusion or stop the transfusion temporarily. And then we will administer the intravenous antihistamine, and we can resume the transfusion 15 to 20 minutes later. So if we have to ask whether the patient having any history of allergy reaction before. So if we know the patient having the history, we can give the antihistamine before or the blood transfusion to prevent this kind of the transfusion reaction. So for the next one is the transfusion transmitted bacterial infection. It can occur with a smaller transfusion volume, for example, a few ml of the blood compared to the hemolytic transfusion reaction. And it happens within the first few minutes of the transfusion. And it's rapidly fatal if we leave the patient untreated. So the patient will experience high fever, chills, vomit, generalized muscle ache, and also hypotension and shock. They will also experiencing bloody diarrhea, hemoglobinuria, and renal failure, and also disseminated intravascular coagulation. So for the organism that most frequently isolated in the platelet concentrate, for example, is the Staphylococcus epidermidis, and the bacteria can grow rapidly in the platelet concentrate stored in between 20 to 22 degrees Celsius. And for the red cell concentrate, for example, is the Yersinia enterocolithica. It will grow at 4 degrees Celsius. However, it does not cause the hemolysis of the red cell, but it produces very powerful endotoxin. So for the treatment, we should stop the transfusion immediately and send the blood product for the microbiological investigation, and also for the blood culture and sensitivity. And then we can do the workup for the acute hemolytic transfusion reaction if we does not sure whether it's due to the hemolytic reaction or bacterial infection. And then we give the appropriate antibiotic, supportive fluid management, and also the vasopressive agent. Next. So for the last one is the anaphylactic transfusion reaction. It happened in the IgA deficiency recipient, which has anti-IgA in their body. So when they receive the blood or plasma containing the immunoglobulin A, it will result in the anaphylactic reaction. So the patient may experience the hypotension, stridor, bronchospasm, and chest tightness, and other GI symptoms like nausea, vomiting, adrenal cramp, diarrhea, but usually they don't feel fever. So for the management, we can start the treatment for any anaphylactic reactions such as intramuscular adrenaline, intravenous hydrocortisone, intravenous chlorpheniramine, and also the supportive treatment like intravenous fluid and airway maintenance, oxygen supplementation, salbutamol nebulization to relieve the bronchospasm, and also the ventilatory support if needed. So if we know the patient with any previous history of anaphylactic reaction, or they are known to be IgA deficient patient, so we should give them the IgA deficient blood product or wash out red blood cell instead of the normal blood product. Yeah. Okay.
I will proceed with the anticoagulants. There are a few indications for anticoagulants, such as venous thromboembolism, whether they recovered with or without sequelae, whether they have the first episode of venous thromboembolism, or the venous thromboembolism is a recurrent case. Also, there are other indications such as atrial fibrillation, cardioversion, mural thrombosis, cardiomyopathy, patients with prosthetic heart valves, whether it's mechanical bileaflet or tilting disc, or mechanical cage ball or cage disc, also recurrent venous thromboembolism while on warfarin therapy. For the contraindications for anticoagulants, it is active bleeding, such as peptic ulcer disease, bleeding tendency, such as patients with hemophilia or thrombocytopenia, patients with uncontrolled hypertension, such as systolic above 200 millimeters mercury, intracranial hemorrhage or large stroke within 2 weeks, pericarditis or pericardial effusion, severe trauma within 2 weeks, or pregnancy, except in women with mechanical heart valves who are at high risk of thromboembolism. Also, warfarin is contraindicated in patients in early pregnancy and towards time of delivery. Patients with unsatisfactory compliance, such as the elderly, debilitated, or psychiatric patients, patients with severe liver disease, or aortic dissection. The first anticoagulant is unfractionated heparin, where it works by potentiating the activity of antithrombin 3 to inactivate the coagulation factors, including thrombin and factor 10A. Also, it prolongs the thrombin time and the activated partial thromboplastin time. The half-life is 45 to 60 minutes, but it is prolonged in patients with severe liver disease. Also, it does not cross the placenta. The monitoring for this drug is not needed in prophylactic unfractionated heparin, but in therapeutic unfractionated heparin, it is achieved by using the activated partial thromboplastin time. There are some side effects of this anticoagulant, such as bleeding, heparin-induced thrombocytopenia, osteoporosis in long-term therapy, and hypersensitivity reactions. For the dosage of this anticoagulant, there are two options. The first option is by bolus of 5,000 units, followed by IV administration of 1,000 units per hour. Then you take the APTT after 6 hours. The second option is by 80 units per kilogram if the age of the patient is less than 70. If the age of the patient is 70 or more than 70, then 50 units per kilogram is given, followed by IV administration of 18 units per kilogram per hour. Then you take the first APTT after 6 hours. There are a few more things about this anticoagulant, such as the monitoring needed. Because HIT, the heparin-induced thrombocytopenia and thrombosis, is a life-threatening complication, then the platelet count must be monitored. Daily platelet count from day 4 of first exposure or day 1 of repeat exposure is ideal. For the reversal of this anticoagulant, you can give IV protamine sulfate, and it's given over slow IV infusion, not more than 50 milligrams over 10 minutes, or in this case, it's 5 milligrams per minute. 1 milligram of protamine will neutralize 100 units of heparin, and you can measure the APTT 5 to 15 minutes after initial dose and then 2 to 8 hours. Another type is low molecular weight heparin, where the drug works by inactivating the factor 10A more than thrombin, and it has more favorable bioavailability and pharmacokinetics, and it binds less to tissue and plasma proteins. This drug does not require routine monitoring, and the half-life is 2 to 4 times more than unfractionated heparin, and it produces a more predictable response. Therefore, you can give once or twice a day in a fixed dose regimen without any APTT monitoring. There are some side effects. Similar to unfractionated heparin, it causes bleeding, HIT, osteoporosis, and hypersensitivity reactions. When compared with unfractionated heparin, it has fewer side effects, but it's just as safe and effective. The difference is it can be given in an outpatient management, and it can be used in pregnant women. Some examples include dalteparin, enoxaparin, nedroparin, tinzaparin, and reviparin. Because the principal route of elimination for this drug is through the renal route, you need to use caution when giving it to patients with renal failure. The third drug is direct oral anticoagulant. There are two types of drug for this type. That's dabigatran and rivaroxaban. Dabigatran is a direct thrombin inhibitor, while rivaroxaban and apixaban is a factor 10A inhibitor. The half-life for dabigatran is 12 to 17 hours, rivaroxaban 5 to 9 hours, apixaban 12 hours. The difference between this drug and warfarin is that it does not require monitoring by international normalized ratio, but the patient still need to come to the clinic for follow-up to monitor the renal function. This drug cannot be used in patients with severely impaired renal function, pregnant patient, patient with antiphospholipid syndrome, prosthetic heart valves, or moderate to severe mitral stenosis. This drug can be said to have some advantages over warfarin, where it does have a fixed dose regime, does not need INR monitoring. It is less susceptible to drug and dietary interaction, and it has a reduced risk of intracranial hemorrhage. But this drug is high in cost. It has a lack of long-term safety data, and there is no readily available specific antidote. Lastly, it's about warfarin, where it works by inhibiting the synthesis of vitamin K in dependent protein factors, factor 2, 7, 9, and 10, and it also reduces protein C. Also, in early warfarin therapy, it can induce a hypercoagulable state. The monitoring for this drug is through INR, and the half-life is 36 to 42 hours. But there is a variation in dose response depending on the patient's race, genetic factors, diet, intercurrent illness, and drug therapy, other drug therapy. There are some side effects such as bleeding, skin necrosis, and fetal abnormalities. The risk factor for this drug, there is a higher risk for bleeding in patients who are older, female, first year period on anticoagulant, patients with higher target INR, high actual INR, and patients indicated to take this drug because of an arterial disease. Also, patients with a previous GI bleed, cerebrovascular disease, hypertension, alcoholism, and liver disease.
Good morning, Prof. Juan and fellow friends. My name is Liwani, and I'm going to continue about INR. So the laboratory parameter that is utilized to monitor warfarin therapy is the PT-INR. So PT is the number of seconds it takes for the blood to clot, and INR allows the standardization of prothrombin time measurement depending on the thromboplastin reagent used by the laboratory. So the formula for INR is patient's PT divided by the controlled PT. And INR is,
I'm sorry, Liwani, is it?
yes.
Liwani, your formula for INR is wrong. So the INR equals to patient's PT divided by the control PT bracket. Okay, correct. But outside the bracket, there are another ratio. There is a fraction, a ratio there. So you might want to redo this slide. So it's not just patient's PT divided by the control PT is there is a bracket. Outside there is a power, a fraction. Okay.
Okay.
Mm.
Okay. Okay. So,
Otherwise, this is just a PT ratio. PT ratio. INR is not a PT ratio. INR is special for the patient on warfarin, and there is a fraction there that is to standardize it, standardize the ratio. Okay.
okay.
Go ahead.
So INR is preferred over PT when monitoring patients of warfarin. So
Mm.
usually, if a normal person who is not on anticoagulation therapy is usually one, and most patients when they are on warfarin therapy, the INR goal is between 2 to 3.
Correct. Except the one that on mechanical prosthetic heart valve. So it will be 2.5 to 3.5, or even a bit higher, 3 to 4. But generally, you all very difficult to remember. You just remember generally is 2 to 3, 2 to 3. Then if there is a mechanical heart valve, is 2.5 to 3.5. Okay.
Then next one is the dietary modification for patients on warfarin therapy. So large amounts of green leafy vegetables, which contains high amounts of vitamin K, can lower the effects of warfarin because vitamin K antagonize the warfarin. So patient has to be advised to take such food in consistent amount to avoid large fluctuations in the INR. Okay, so these are the examples of vegetables and food that are high in vitamin K, and on the other side are the vegetables that are low in vitamin K. And then these are the examples of herbals and also supplement that can interact with warfarin. So on the left side, it are the examples of supplements that can increase the warfarin effect, therefore will increase the INR. And patient will have increased INR, then risk of bleeding. And then on the right side are the examples of supplements that can decrease warfarin effect, which will then decrease the INR, and patients will have risk of blood clot. And then next one I will talk about counseling for patients who are on warfarin therapy. So first of all, we have to explain to the patients or what is warfarin. So basically, it is a blood thinning medication that prevents blood clot and which can further prevent occurrence of a stroke. So how warfarin works is that they will inhibit an enzyme which the specific name is vitamin K epoxide reductase, which will then decrease vitamin K, and then it will decrease vitamin K depending clotting factor, therefore will decrease coagulant activity, and then it will cause the blood thinning effect. And then we also have to explain the indication and also duration of warfarin to the patient. So for example, if the patient has atrial fibrillation, then we have to tell them that this warfarin therapy has to take lifelong. And then the dosage of warfarin, usually it will change based on the regular INR test that was performed on the patient. And then next one, we also have to, the patient will be given an anticoagulation book, and we have to explain to the patient about the importance of the book and also the content of the book. Okay, next. Okay, so then after that, we have to explain to patient how do they have to take the drug. So the drug have to be taken every day at the same time, usually around evening. And if the patient miss one dose, they have to take the warfarin as soon as they remember or before 12 midnight. And also have to advise the patient that do not double the dose the next day to make up for the missed dose a day before. And they also have to remind that they cannot stop taking warfarin without any instructions from the doctor. And then next one, we have to explain them about the blood test, which is INR monitoring. The main aim, it is to check the response of warfarin, and the main aim is to keep the INR between the certain reference range. So if the INR fall out of the range, then as a doctor, we may have to change the dosage of the warfarin. And we also have to tell the patient that INR test is usually done more frequently during the first few months of warfarin therapy. So after that, once the dose is determined, INR test will be done less frequently. Okay, next. And we have to tell patient about the side effect of warfarin. So the main one is bleeding problems, and we have to tell them that if any bleeding happen, they have to seek medical attention immediately. And we also have to brief about them about the drugs and also food interaction with warfarin, and they have to be reminded to take a consistent diet with the same amount of leafy vegetables every day, and also avoid cranberry juice or any alcohol products because this can interact with warfarin. And they have to avoid taking NSAIDs such as ibuprofen and also naproxen and also aspirins for any pain management because this can increase their risk of bleeding because while they are on warfarin therapy. And next one is that we have to tell the patient whenever they go for any surgical or dental procedures, they have to tell the doctor or dentist in charge that they are on warfarin. And lastly, we have to educate patients on signs and symptoms of stroke, deep vein thrombosis, and also pulmonary embolism, and have to immediately go to seek medical attention if the symptoms appear. Okay, next. This was taken from the patient's anticoagulation book. So these are the things that the patient have to do and also cannot do throughout when they are on warfarin therapy. Then this is the detailed explanation of warfarin education. Yep, next.
Okay.
Next. Okay, the last part will be the management of over-warfarinization. So bleeding while patients on anticoagulation increase significantly with INR more than 5. And then the therapeutic decisions depend on the INR, the severity of the hemorrhage, and also the urgency. Okay, next one. Okay, so the first condition is life-threatening hemorrhage or emergency needing fast reversal. So if patient presented with this, we have to give 1 dose of 4-factor prothrombin complex concentrate. So this PCC, it can reverse INR after 10 minutes, and the effect lasts between 12 to 24 hours. And the INR, if the INR of the patient is less than 5, then 15 units of PCC per kg is used. If the INR is 5 or more than 5, 30 units per kg is used. And this PCC has must combine with vitamin K for sustained reversal. And because it contains heparin, so it is contraindicated if the patient has history of heparin-induced thrombocytopenia. So if there is no PCC, fresh frozen plasma can be given to the patient with 15 ml per kg. And we also have to be combined with vitamin K for sustained reversal. And then the dosage will be 5 to 10 milligrams low IV infusion over 30 minutes. And it can usually reverse INR within 12 to 24 hours, which takes longer time as compared to PCC, but it can render patient refractory to warfarin, but not to heparin for about 2 weeks. Next. The second condition is less severe hemorrhage, for example, hematuria or epistaxis, and the INR is more than 5. So firstly, we have to withhold the warfarin for 1 day or more, and then the INR will be reduced by 1 per day. And then we also can consider 4-FPCC or fresh frozen plasma plus vitamin K 0.5 to 2.5 milligram IV or oral. And then we can restart warfarin at a lower dose once the bleeding has stopped. Okay, next. So the last condition is insignificant or no hemorrhage, but patient's INR is above the therapeutic range. So if the INR is more than 8, we have to withhold the warfarin and give vitamin K 2.5 to 5 milligram IV or oral if risk factors for bleeding presented. So the risk factors include old age, high actual INR, or any previous GI bleed. And we have to repeat INR daily, and the INR should reduce in 24 to 48 hours. Next one is when the INR is between 5 to 8. We have to omit 2 doses of warfarin and repeat INR till it is within the therapeutic range. And then after that, we can restart warfarin at a lower dose. If the patient is at high risk of bleeding, then we can give vitamin K. And then the next one is INR less than 5. We have to omit next warfarin dose and resume the warfarin at lower dose with INR approaches the desired range.
Okay, good morning, doctor. So this will be the final part in our discussion today. Okay, so for hemostasis. Hemostasis is actually a process to maintain the blood in fluid state, which is also to function the blood as a transport system. Usually the blood will clot in order to prevent any form of excessive bleeding after the vascular injury. So these are the stages in hemostasis. Next. Okay, so for primary hemostasis, the component involves a platelet, 1 Willebrand factor, and also vessel size. So these are the processes involved in primary hemostasis. I will explain detail in next slides. Okay, so for primary hemostasis, first, as you can see in the picture on your right, picture A, it's showing the vessel constriction, which is the first step in primary hemostasis. Once there's a vessel injury, the vessel will undergo constriction in order to prevent further bleeding. So this will activate the coagulation in which the platelets will come into contact and adhere to the collagen and subendothelial 1 Willebrand factor. This will activate. This will also will proceed with the platelet adhesion process. So after second of adhesions of the platelet will undergo change in shape from disc to sphere in order to spread, in order to be helpful to spread the platelets along the subendothelial and releases its content such as ADP, serotonin, and platelet activating factor. This is known as the platelet activation process. So once the ADP activates the fibrinogen receptor, this will allow the platelet to bind to the fibrinogen, and this will cause the platelet aggregation process, which the platelet will form a bridge between the platelets. Next. So for secondary hemostasis, which is mainly the clot formation. So this will, after the activation of coagulation factors such as plasma protein, the thrombin will be generated. The thrombin will help in the converting the fibrinogen into the fibrin, which will form the clot. The phases involved in secondary hemostasis are initiation, amplification, and propagation. So for tertiary hemostasis, which is mainly for fibrinolysis, this is a process to help to restore the vessel patency after the vascular damage. This is by the enzyme plasmin, and the stabilization of the clot is by factor 13. So the dissolution of the clot will be done by the fibrinolytic system. So you can see detail in the picture on your right. So next. So this is the summarize of the hemostatic process, which involving the primary, secondary, and tertiary. So classification for bleeding disorder. The bleeding disorder can be classified into vascular disorder, platelet disorder, and also coagulation disorder. So for vascular disorder, there are congenital causes such as hereditary hemorrhagic telangiectasia or connective tissue disorder, which are commonly Ehlers-Danlos syndrome, osteogenesis imperfecta, and also Marfan syndrome. So for acquired cases, severe infection, autoimmune diseases, drug-induced disorder, usually due to steroids, and other causes such as scurvy and also senile purpura. For platelet disorder, it can be divided into quantitative, which is thrombocytopenia, in which there will be due to decreased production, such as bone marrow failure, increased destruction due to immune-mediated ITP or non-immune-mediated TTP and VIC. Also due to sequestration and also dilutional causes. For acquired causes, acquired could be due to drug-induced uremia, liver diseases, and hereditary due to von Willebrand diseases and other causes.
Mona.
Yes,
Go back. So your platelet disorder acquired. So under your acquired, you got acquired and hereditary again. So it is contradicting yourself.
Oh, yeah. So there'll be quantitative, acquired, and hereditary, is it, doctor?
Yeah, so in the under the quantitative, then it will be qualitative instead of acquired.
Oh, okay, doctor.
Mm.
Okay, thank you, doctor.
Mm.
Okay, so for coagulation disorder, it can be divided into inherited and acquired. So for inherited is due to X-linked recessive traits such as hemophilia A and B, and autosomal dominant, which is von Willebrand disease. For acquired, it could be due to any form of vitamin K deficiency, liver diseases, DIC, and also fibrinolytic defect. So for causes of bleeding, according to the severity. So as you can see in this diagram, if you see in ascending order, it is determining the severity of bleeding. So on the top of the list, which is the Glassman, which is due to the Glassman is actually a rare cause of bleeding, and it is due to impact function of specialized cells such as platelet. So Glassman, Bernard-Sirleaf, and von Willebrand disease variant and severe hemophilia is actually a very severe form of bleeding. So when you say in descending order, which is the bleeding of undefined cause, the top bottom list, is actually more difficult to diagnose. So what we can see from this diagram is actually the most severe form of bleeding will be usually diagnosed easily. Next. So for investigations, first investigation is full blood count. As usual, we have to look for any form of blood disorders such as anemia, leukemia, and lymphoma. And for coagulation profile, we have to look for any, you have to rule out for coagulopathy, prolonged PT, and APTT. So for coagulation profile, we have to collect the blood into a citrate. The tube will contain citrate in order to prevent clothing and also to neutralize the calcium ion. So for bleeding time, we have to, there'll be prolonged in bleeding disorders, and BUS and creatinine is actually to rule out uremia, because uremia can be complicated with coagulopathy. Next is for peripheral blood smear to rule out any abnormal cell morphology, such as blood malignancy, D-dimers to look for any DIC, and other investigations such as platelet aggregometry, von Willebrand factor assay, other specific factors, and also PTT mixing studies.
The mixing study can be done. Go back one slide. So the mixing study can be done for PTT and PT. So probably it's better that you put coagulation profile and mixing test instead of putting the mixing test under others. We seldom do bleeding time nowadays because it's not specific, okay, and not accurate, and you can do a serum fibrinogen level, okay, if you are suspecting of low fibrinogen, okay. So investigation, you can modify a little bit, okay. Continue.
Okay, doctor. So for coagulation tests in detail, on the picture on your left, you can see what are the what are the parameters that we have to look during the coagulation test. So the reference range is also there, and also diagnosis and differential diagnosis for the specific causes. So if you see in detail for prothrombin time, it's actually to look for any, to assess the intrinsic pathway of the, especially the factor 677. And also, so if the prothrombin time is prolonged, it is due to liver diseases or patients on warfarin or factor deficiencies, which is the factor 7. Next, for activated partial thromboplastin time, APTT, it is used to assess the intrinsic pathway, which is factor 12, factor 11, 9, and also 8. So this, if it's prolonged, it is due to that factor deficiency. So if you can see in PT and APTT, there's similar factors, which is the factor 5, factor 10, prothrombin, and fibrinogen. This is because all these 4 factors are involved in the common final pathway. So if PT and APT is prolonged, it is due to that specific factor deficiency. And other causes for prolonged PT and APTT is usually due to global coagulation factor deficiency involving more than one factor, which is usually occur in DIC. And in von Willebrand disease, usually they may present with normal APTT.
Okay, I think you can.
Okay. So this is a slide about the parameters. Next, previous slide. It's okay.
I
We
think
can just
we can skip this one.
yeah. For initial management of bleeding, we have to first assess ABC. Next slide. Okay, thank you, Swami. Okay, so for initial management of bleeding, we have to first assess ABC and also resuscitation if necessary. Okay, so first we have to secure the airway. We have to maintain the SpO2 more than 94%, and also IV fluid for resuscitation. And blood should be taken for investigations such as food count, BUS, and other investigations that I've stated just now. So we have to continuously monitor the vital sign, input-output charting, and correct electrolyte imbalance if indicated. And also it is important to proceed with physical examination and history taking. We have to take the blood for further investigation such as peripheral blood film and D-dimer, which is to rule out the TTP. So next we have to transfuse appropriate blood products, in which low hemoglobin only we have to transfuse packed cell. For deranged coagulation profile, we have to transfuse fresh frozen plasma. For thrombocytopenia, first we have to exclude TTP and HIT, which is the heparin-induced transfusion, thrombocytopenia first before doing the platelet transfusion. Next, we have to watch out for sign of hypovolemic shock and septic shock, and also further proceed with further management depending on the cause of the bleeding.
Have you all learned about emergency or?
Sorry, doctor?
Have you all learned about emergency or?
I'm not sure, doctor.
In an emergency where you cannot wait for the full group cross match, you can give emergency group O blood to the patient. Okay, so you can put it somewhere there, or maybe under one as says ABC resuscitation if necessary, IV fluid for resuscitation. Then you maybe can add on emergency or if indicated. If the patient is very pale, you do not need the full blood count to tell you to confirm that and the patient is hypotension. So sometimes you can give an emergency, or if you really cannot push up the blood pressure after the IV fluid. So maybe you add another sentence there. Okay.
Okay, doctor.
Continue.
Okay, so this is the final slide. So this is to summarize all the causes of bleeding disorder and the investigation and the management about the bleeding disorder. Should I explain further, doctor?
Very busy slide. Let them read themselves. Okay.
Yeah, that's all.
Okay. So
Okay.
you all got any question or not? Oh, very quiet. So, okay. If not, so no question, huh? Okay. If no question, Suhaimi, can you stop sharing? Okay. So let me hold on now. Okay. If there's no question, oh, by the way, and the slide that Suhaimi, you sent me, I uploaded. Is it the same as today's one?
It's same.
It's the same, huh? Okay. You all might want to do some correction. Then Suhaimi, you email me again, then I upload in the Elite so that everyone can download and nobody can give excuse that the presenter did not give you all the copy. Okay, so Suhaimi, you can email me later. So we will put up I will put up in the Elite. Maybe today is Tuesday, so you all give me by Thursday. I upload it by this Friday, okay?